Hello everybody. Today we are going to discuss about acute pancreatitis. Uh, so we have this 31-year-old male patient with no comorbidities. He came with a chief complaint of sharp epigastric pain, left iliac region pain associated with nausea and vomiting, with distension of abdomen, high colored urine, X-ray abdomen done suggestive of mild dilation of the bowel lumen. USG abdo-pelvis done, which was suggestive of mild hepatomegaly and mild fatty infiltration of the liver, mild ascites and bilateral pleural effusion. CT abdomen was done, which was suggestive of necrotizing pancreatitis, splenic vein thrombosis extending to portal vein, mild ascites with bilateral pleural effusion. For anticoagulation, heparin was started. Later, patient had episode of hematuria. CCT done in the view of hematuria, which was suggestive of bilateral hydronephrosis. Cystoscopy was done, which showed bilateral ureteric clots. Bilateral degestanting was done. After degestanting, hematuria gradually improves. I repeat, portal venous Doppler done, which showed a complete resolution of thrombosis. Considering the risk of recurrent portal venous thrombosis, he was started on tablet apixaban 2.5 mg. So the final diagnosis of the patient was acute necrotizing pancreatitis, portal vein thrombosis, acute kidney injury, obstructive uropathy. So we'll see what is this acute pancreatitis and how to manage. Acute pancreatitis represents the mild self-limited disease, but in 15% to 25% patients, severe pancreatitis develop manifested with the pancreatic parenchymal or peripancreatic tissue necrosis. Pancreatic necrosis accounts for substantial additional morbidity, with the mortality remaining as high as 10% to 20%. So, definition acute pancreatitis is best defined clinically by a patient representing symptoms, that is epigastric pain consistent with pancreatitis, serum amylase or lipase greater than 3 times the lab upper limit of normal, radiological imaging consistent with the pancreatitis, usually computed tomography or MRI. So the causes of acute pancreatitis, gallstone are the most common cause. Alcohol is the second most common cause of acute pancreatitis. Prolonged alcohol use, that is 4 to 5 drinks daily over a period of 5 years, is required for alcohol-associated pancreatitis. The risk is higher for men than for females. The mechanism by which alcohol causes acute pancreatitis are complex, and it includes both direct toxicity and immunological mechanism. Drug appear to cause less than 5% of causes of acute pancreatitis, and the drug strongly associated with the disorders are azathioprine, 6-mercaptopurine, didanosine, valproic acid, angiotensin converting enzyme inhibitor, and mesalamine. Now, the next cause is genetic cause. Mutation in the polymorphism in the number of genes are associated with the acute pancreatitis, including mutation in the genes encoding cationic trypsinogen, that is PRSS1, serine protease inhibitor, Casal type 1, that is SPIK1, cystic fibrosis transmembrane conductance regulator, that is CFTR, and chymotrypsin C, calcium sensing receptor, and crowdin. Other risk factors include smoking, environmental toxin, morbid obesity, and type 2 diabetes. Now, the clinical presentation is abdominal pain present at the onset of most attack of acute pancreatitis. Pain in the pancreatitis usually involves entire abdomen, uh, and it may be epigastric in right upper quadrant or infrequently confined to the left side. It is at maximal intensity in 10 to 15 or 20 minutes. Pain gradually increases and takes several hours to reach maximal intensity. So this pain is steady and moderate to very severe. There is little pain relief with the changing position. Now the pain is radiating to back in half of the patient. Pain may have pleuritic component, may be associated with rapid or shallow respiration. Pain is described as knife-like sensation that passes straight to the mid-central back from epigastric. Now we'll see what are the physical examination findings. Patients with acute pancreatitis typically appear anxious and ill. They may be diaphoretic or hyperthermic. Tachycardia, tachypnea, hypotension are common. Patients often roll on or move around in search of more comfortable position. Unlike those with peritonitis caused by perforated viscus, which remain motionless because movement will exacerbate their pain. Most patients with acute pancreatitis have clear sensorium, but some have mild or even severe alteration in their mental status as a result of drug and ethanol exposure. The abdominal examination of the patient with acute pancreatitis usually reveal abdominal tenderness. The tenderness is limited to epigastrium or diffusely present throughout the abdomen. Abdominal distension also can be seen, especially epigastric, which is due to gastric, small bowel, or colonic ileus. Hypovolemia and dehydration are commonly present and can be detected by the presence of hypotension, tachycardia, collapsed neck vein, dry skin, dry mucous membrane, and decreased turgor. Vowel sounds are often diminished or absent. Flank ecchymosis, that is Gray Turner sign, or other evidence of retroperitoneal bleeding, that is Cullen sign, may be noted. Examination of the chest may reveal evidence of pleural effusion that may be on either or both sides, but is most commonly present on the left. Because of the pleuritic or abdominal pain, deep breathing is difficult and atelectasis, particularly at bases, is common. Examination of the skin may reveal the areas of tender subcutaneous induration or erythema that resemble erythema nodosa. These lesions are believed to result from fat digestion by circulating pancreatic lipases. Now, what are the differential? So, differential includes perforated holoviscous, cholecystitis, cholangitis, bowel obstruction, mesenteric ischemia, and infarction. So, we'll see how to evaluate what are the lab tests and radiological examination. So, this acute pancreatitis is associated with the significant loss of intravascular fluid. These losses of the fluid from intravascular compartment can cause hemoglobin, hematocrit, blood urea nitrogen, and serum creatinine to rise. Hypoalbuminemia is common, but the serum electrolyte may remain normal unless vomiting has been significant. Because of the pancreatic inflammatory process, the white blood cell count is elevated and neutrophilic predominance type of picture is seen. Hyperglycemia, which commonly is noted, may result from the combined effect of elevated circulating catecholamine, decreased insulin release, and hyperglucemia. A mild rise in serum bilirubin from non-obstructive cholestasis frequently is seen even with non-biliary acute pancreatitis. When the disease is induced by the passage of gallstone, the hyperbilirubinemia is even more marked, and superimposed cholangitis with bacteremia and positive blood culture can. Markedly elevated circulating triglyceride levels always are seen in individuals whose pancreatitis is caused by hyperlipoproteinemia. But hypertriglyceridemia with the lactation serum also can be seen in alcohol-induced acute pancreatitis. Hypocalcemia is relatively common among individuals with the acute pancreatitis. Hypocalcemia is caused by hypoalbuminemia, and as a result, the ionized calcium level is actually normal. For some patients, however, hypocalcemia can develop that is out of proportion to the degree of hypoalbuminemia that reflects the two increase in circulating ionized calcium levels. Tetany and carpopedal spasm and other complication of hypocalcemia may develop among these patients. Marked hypocalcemia has been considered to be the sign of poor prognosis. In patients with the severe pancreatitis, disseminated intravascular coagulation may develop, and as a result, they may have thrombocytopenia, elevated level of the fibrin degradation product, decreased fibrinogen level, and the prolongation of partial thromboplastin and prothrombin types. Now, the pancreatic enzymes and other assays. Serum pancreatic enzyme measurement is the gold standard for diagnosis of acute pancreatitis. In an episode of acute pancreatitis, amylase, lipase, elastase, trypsin are released into the bloodstream at the same time, but clearance varies. The amylase, it is an enzyme secreted by pancreas and also by salivary gland, small intestine, ovaries, adipose tissue, and skeletal muscles. There are two major isoforms of amylase, that is pancreatic amylase and salivary amylase. The leading function is the digestion of starch, glycogen, related polysaccharides, and oligosaccharides. In acute pancreatitis, serum amylase levels usually rise within 6 to 24 hours, peaks at 48 hours, and decrease to normal, near normal level over next 3 to 7 days. Lipase is the another enzyme secreted by pancreas. Lipase is more specific but can be found elevated in non-pancreatic disease such as renal disease, appendicitis, acute cholecystitis, chronic pancreatitis, and bowel obstruction. In acute pancreatitis, serum lipase remains elevated for longer period than serum amylase. It rises within the 4 to 8 hours, peaks at 24 hours, decreases to normal or near normal level over next 8 to 14 months. Trypsinogen is the zymogen of pancreatic enzyme trypsin. In acute pancreatitis, the serum and urinary concentration of trypsinogen usually rise to high level within few hours and decrease in 3 days. Trypsinogen 2 dipstick test is a rapid and non-invasive bedside test with sensitivity of 82% and specificity of 94% for acute pancreatitis. In the absence of gallstone or significant history of alcohol use, serum triglyceride should be measured and considered to be etiology if value is more than 1,000. The C-reactive protein is the gold standard for disease severity assessment. If C-reactive protein is more than or equal to 150 at third day, it can be the prognostic factor for severe acute pancreatitis. Resistin is the newly identified peptide hormone secreted specifically by adipocyte that can cause obesity and hypertriglyceridemia due to its association with the insulin resistance. Resistin levels were better for predicting severe acute pancreatitis than CRP or WBC level on day 3 and better than CRP level for predicting the development of necrosis. PCT is the most sensitive lab test for detection of pancreatic infection, and low serum values appear to be strong negative predictor of infected necrosis. So the lab features suggestive of severe acute pancreatitis are BUN more than 20 mg per dl or rising BUN, hematocrit levels more than 44 or rising HCT, PCT for predicting infected necrosis in patient with the confirmed pancreatic necrosis. Now we'll see what are the radiological investigations. Transabdominal ultrasonography should be performed on admission or in first 48 hours for detecting gallbladder stone and bile duct dilatation or both. Endoscopic ultrasound can help in investigation of biliary tree for evaluation of gallstone pancreatitis. CECP is the imaging modality of choice for diagnosis, staging, and detection of complications. When diagnosis is uncertain, CT should be considered, especially to rule out secondary perforation peritonitis or ischemic mesentery. It also shows active hemorrhage and the thrombosis associated with the pancreatitis. With the help of CT severity index, we can grade severity of pancreatitis. Early CT scan will not show necrosis or ischemic areas and will not modify the clinical match. The extension of peripancreatic necrosis may be detected with contrast-enhanced CT after 72 hours from onset of acute pancreatitis. MRI is preferable to CVCT in patient with allergy to iodinated contrast, in patient with renal impairment or insufficiency, and in young or pregnant patient to minimize radiation exposure, but is less sensitive than CT for detecting gas in fluid detection. Patient with acute pancreatitis on concurrent cholangitis should undergo ERCP within 24 hours of admission. ERCP is not needed in most patients with gallstone pancreatitis who lack lab and clinical evidence of ongoing biliary pancreatitis. In the absence of cholangitis or jaundice, MRCP and endoscopic ultrasound rather than diagnostic ERCP should be used to screen choledocholitis if highly suspected. Now, after evaluation, after everything, now it's our job to predict the severity. How much severe is this pancreatitis, so that we can counsel the relatives of the patient. So first is BSAP score, Revised Atlanta classification, CT severity index, Ranson score, and Apache score. So the first we'll see the bedside index of severity of acute pancreatitis, that is BSAP score. So according to this score, the blood urea nitrogen levels more than 8.9, impaired mental status, systemic inflammatory response syndrome, age more than 60 years, pleural effusion on radiography. So each of these criteria will carry one. If the points are 0 to 2, then that has low mortality. That is less than 2%. If it is 3 to 5, then it has a high mortality more than 50%. Now the next is revised Atlanta classification. It includes four categories like mild acute pancreatitis, moderate severe acute pancreatitis, severely acute pancreatitis, and critical acute pancreatitis. So when we'll say it's mild, when there is no organ failure, no local or systemic complication, and moderate severe acute pancreatitis, we can label it as moderate severe acute pancreatitis when there is a transient organ failure. That is, organ failure was there but resolved within 48 hours, or local or systemic complication without persistent organ failure. To call it as severe acute pancreatitis, there should be the presence of persistent single or multiple organ failure. And critical acute pancreatitis, persistent organ failure, and infected pancreatic necrosis. Though the next is Ranson criteria. So Ranson criteria on admission, it includes age more than 55. So we'll get all blood investigation, and in that, if we'll see WBC count more than 16,000, if blood glucose is also high, that is more than 200. If there are high LDH values, that is more than 350. If this glutamic oxaloacetic transaminase level, that is SGOT, is more than 250, then and after initial 48 hours, if hematocrit decreases more than 10%, if blood urea nitrogen rise of more than 5%, if serum calcium levels are more less than 8, if partial pressure of oxygen is less than 60, base deficit is more than 4, and fluid sequestration is more than 6 liter, then we should uh, the further categorization of the Ranson's criteria is the based on the Ranson score. That is, if the score is 0 to 2, then that has minimal mortality. If score is 0 to 3 to 5, then it has a 10 to 20% of mortality. If this Ranson score is more than 5, then it has a 50% mortality. So all these carry 1 point, and these also carry 1 point, and according to that, we need to calculate. Now the next is city severity index. So based on this city abdo, we need to categorize this pancreatitis, grade the severity of this pancreatitis. If it is a normal pancreas without peripancreatic enhancement, then the city severity score is 0. If there is a focal and diffuse enlargement of the pancreas, then it is 1. Peripancreatic inflammation without intrinsic pancreatic abnormality, then it has a 2 score. If there are intrapancreatic and extrapancreatic fluid collection, it has a 3 score. If there are 2 or more large collection of gas in pancreas or retroperitoneum, then it has a 4 score. Now and the maximum, if this score is more than or equal to 6, then it has a severe disease. Now based on the necrosis, if it is a 0% necrosis, 0 score, less than 33% necrosis, 2 score, 33 to 50% necrosis, 4 score, and more than 50% necrosis, 6 score. So there is no gold standard score for prognostication, and the BISAP is the one of the most accurate and applicable in everyday clinical practice, because it is very simple and it has a capacity to predict severity, death, also organ failure. Now the next is idiopathic pancreatitis, like our patient has. He was finally diagnosed as idiopathic. So idiopathic acute pancreatitis is defined as pancreatitis with no etiology established after lab and imaging testing. In patient with the idiopathic pancreatitis, at least 2 US ultrasound examination should be performed to rule out biliary pathology. Following that, CCT and ultrasonography, endoscopic ultrasonography, after acute phase is over, the next step to assess microlithiasis, neoplasm, and chronic pancreatitis. If endoscopic ultrasound is negative, MRI should be performed to identify morphological abnormalities. Then laparoscopic cholecystectomy seemed to prevent recurrent idiopathic acute pancreatitis. Now we'll see what are the complications of acute pancreatitis. These complications are divided into early complication and late complication. So early complication includes respiratory failure, renal failure, sometimes GI bleed, DIC, visual disturbance, metabolic disturbance, pancreatic necrosis, and acute pancreatic fluid collection. And late complication includes pseudocyst, walled-off necrosis, perforation, and obstruction. So regarding the management of pancreatitis, initial management. So initial management is just aggressive hydration, which is defined as 250 to 500 ml per hour of isotonic crystalloid solution that should be provided to all patients unless cardiovascular and renal comorbidities exist. So this early aggressive intravenous hydration is most beneficial in first 12 to 24 hours and may have little benefit beyond. So this lactated ringer solution may be preferred over isotonic crystalloid replacement. Now, this fluid requirement should be assessed at frequency interval within 6 hours of admission and for next 24 to 48 hours. And the goal of aggressive hydration should be to decrease the blood urea nitrogen. Now, regarding this fluid therapy in pancreas, recently in NEGM, there is the waterfall trial was published. So, according to this trial, the aggressive fluid resuscitation consisting of 20 ml per kg of weight followed by 3 ml of per kg per hour and moderate fluid resuscitation was used consisted of bolus of 30 ml per kg in patient with hypovolemia or no bolus in patient with normal volume, followed by 1.5 ml per kg per hour in all patients in this group. And then they assess the patient at 12, 24, 48, and 72 hours. Fluid resuscitation was adjusted according to the patient's clinical status. And what they have found is early aggressive fluid resuscitation resulted in higher incidence of fluid overload without improvement in the clinical outcome. So this was the waterfall trial. So after this trial, the clinical practice was to means we have clinical practice was the it was the more in the favor of moderate fluid resuscitation than the aggressive fluid resuscitation. And the moderate fluid resuscitation was consisted of bolus of 10 ml per kg body weight in patient with hypovolemia followed by 1.5 ml per kg per hour. Now, after taking care of the hydration, the next point in the management is the nutrition. In patients with the mild acute pancreatitis who do not have organ failure or necrosis, then there is no need for complete resolution of the pain or normalization of pancreatic enzyme before oral feeding is started. So we can start with the low fat solid diet. It's solid diet and this is associated with the shorter hospital stay than the clear liquid diet with the with slow advancement to the solid. So most patients with the mild acute pancreatitis can be started on the low fat diet as soon after admission in the absence of severe pain, nausea, vomiting, and IBS. So regarding this, there was a Python trial which compared early enteral feeding to nasogastric feeding versus oral. And this trial did not show the superiority of early nasogastric tube feeding as compared to oral diet after 72 hours in reducing the rate of infection or death in patients with acute pancreatitis at risk for infection complications. So this is the trial which was published in NEGM, which compared early versus on-demand nasoenteric tube feeding in acute pancreatic necrosis. And the conclusion, this trial did not show the superiority of early nasogastric tube feeding as compared with the oral diet after 72 hours in reducing the rate of infection or death. A need of artificial enteral feeding may be predicted by day 5 on the basis of symptoms that continue to be severe or inability to tolerate attempts at oral feeding. Nasogastric or nasoduodenal feeding is clinically required, and the total parenteral nutrition should be reserved for rare case in which enteral nutrition is not tolerated or nutrition goals are not met. Now regarding antibiotic therapy. The routine use of prophylactic antibiotics in patients with the severe acute pancreatitis is not recommended. So when to give antibiotics? So antibiotics should be given for extra pancreatic infections such as cholangitis, catheter-acquired infection, bacteremia, urinary tract infection, pneumonia, and the use of antibiotic in patient with the sterile necrosis to prevent the development of infected necrosis is not recommended. So, in patient with infected necrosis, antibiotic known to penetrate necrosis, such as carbapenem, quinolone, metronidazole, may be useful in delaying and sometimes totally avoiding intervention. Now, the routine administration of antifungal agent along with prophylactic and therapeutic antibiotic is not recommended. Usually, in an intra-abdominal infection, we are starting prophylactic antifungals, but in case of pancreatitis, it's not recommended. Now, the indication for percutaneous and endoscopic drainage for pancreatic collection. Infected necrosis should be considered in patients with pancreatic and extrapancreatic necrosis who deteriorate or fail to improve after 7 to 10 days of hospitalization. So, in this patient, either initial CT-guided fine needle aspiration for gram stain or culture to guide the use of appropriate antibiotic. So the empirical use of antibiotic without CT aspiration should be given after 4 weeks of onset of disease in case if there is ongoing organ failure without signs of infected necrosis, ongoing gastric outlet, biliary or intestinal obstruction due to large wall of necrotic collection, disconnected duct syndrome, symptomatic and growing pseudocyst. So, what are the indications for surgical intervention? Intervention for necrotizing pancreatitis should be preferably done when necrosis has become walled off, usually after 4 weeks after onset of disease. Signs or strong suspicion of infected necrosis in symptomatic patient require intervention. Small number of patients have been shown to recover with antibiotic alone. So when patient deteriorates, step-up approach starting with percutaneous or endoscopic drainage is indicated. So this walled off and necrotic connection or pseudocyst may cause symptom and mechanical obstruction. If they do not resolve when inflammation ceases, a step-up approach is indicated. Now, this trial again was published in NEJM. In this, the background of this trial was necrotizing pancreatitis with infected necrotic tissue is associated with high rate of complication and death, and standard treatment is open necrosectomy. And the outcome may be improved by minimally invasive step-up approach. And the conclusion was minimally invasive step-up approach as compared to open necrosectomy reduce the rate of composite endpoint of major complication or death among patients with necrotizing pancreatitis and infected necrotic tissue. Now, there was a trial which was published in NEJM, which compared immediate versus postponed intervention for infected necrotizing pancreatitis. So, this infected background of this study was infected necrotizing pancreatitis is potentially lethal disease that is treated with the use of step-up approach with the catheter drainage often delayed until the infected necrosis is encapsulated. So, whether outcome can be improved by early catheter drainage was unknown. And the conclusion was the trial did not show the superiority of immediate drainage over postponed drainage with regard to complication in patient with infected necrotizing pancreatitis. So, recommendation regarding the timing of cholecystectomy. So, the laparoscopic cholecystectomy during index operation is recommended in mild acute gallstone pancreatitis. When ERCP and sphincterectomy are performed during index admission, the risk of recurrent pancreatitis is diminished. But same admission cholecystectomy is still advised since there is increased risk of biliary complication. In acute gallstone pancreatitis with peripancreatic fluid collection, cholecystectomy should be deferred until fluid collection resolve, stabilize, or acute inflammation ceases. Now we'll see what is the summary of AGA guidelines for management of acute pancreatitis. In patient with acute pancreatitis, AGA suggests the using goal-directed therapy for fluid management. In patient with acute pancreatitis, AGA makes no recommendation whether normal saline or vinegar lactate is used. AGA suggests against the use of HES fluid. that is hydroxyethyl starch. In patient with the predicted severe acute pancreatitis or necrotizing pancreatitis, AJ suggests against the use of prophylactic antibiotics. In patient with the acute biliary pancreatitis and no cholangitis, AJ suggests against the routine use of urgent ARCP. In patient with acute pancreatitis, AG is recommended early oral feeding as tolerated rather than keeping the patient nil by mouth. In patient with acute pancreatitis and inability to feed orally, AGA recommended enteral rather than parenteral nutrition. And in patient with the predicted severe and necrotizing pancreatitis requiring enteral tube feeding, AGA suggests either NG or NJ route. In patient with acute biliary pancreatitis, AGA recommended cholecystectomy during initial admission rather than after discharge. Mhm. And in patient with the acute alcoholic pancreatitis, AJ recommended brief alcohol intervention during admission. Thank you.